to Personality Disorders, Part 2. Dependency personality disorder is characterized by a lack of self-confidence and extreme reliance on others to take responsibilities for them. Clinical picture. Individuals' personality disorders have a notable lack of self-confidence that is often apparent in their posture, voice, and mannerism. The picture continued. So these individuals are overly generous and thoughtful while underplaying their own attractiveness and achievements. Low self-esteem, easily hurt by criticism and disapproval. Avoid positions of responsibility and become anxious when forced into them. Assume passive and submissive roles in the relationship. Predisposing factors. Heredity may play a role in it. However, psychosocially, when an infant becomes dependent on one source for stimulation and nurturing, the infant becomes attached to that one source and excludes all others. And the problem may arise when a parent becomes overprotective and discourages independent behavior. And then dependent behavior is rewarded in this environment, and a child may come to fear a loss of love or attachment from the parental figure if independent behaviors are attempted. Obsessive compulsive personality disorder. These individuals with OCD are very serious and formal and have difficulty expressing their emotions. They are overly disciplined, perfectionists, and preoccupied with rules. They are inflexible about the way in which things must be done and have a devotion to productivity to the exclusion of personal pleasure. An intense fear of making mistakes lead to difficulty with decision making. The disorder is relatively common and occurs most often in men than women, and within the family, it appears to occur more commonly with the oldest child. Obsessive compulsive personality disorder, the clinical picture. So these individuals are especially concerned with matters of organization and efficiency. They are sometimes rigid and unbending. Socially, they can be polite and formal. They are concerned with rank consciousness. So if someone is a power, they have an ingratiating tendency towards authoritative figures. So they are trying to appease authoritative figures. However, autocratic and condemning behavior for subordinates. So they are very concerned with where a person ranks. Obsessive compulsive personality disorder, clinical picture continued. So on the surface, they appear very calm and controlled. Underneath, there is a great deal of ambivalence, conflict, and hostility. Predisposing factors to OCD. So over-controlling parents, notable parental lack of positive reinforcement for acceptable behaviors, frequent punishment for undesired behaviors. And we have ourselves a question. So a client diagnosed with personality disorder is cold, aloof, and avoids others on the unit. The nurse recognizes that this behavior is a symptom of which personality disorder? Schizoid personality disorder, A. B. Dependent personality disorder. C. Borderline personality disorder. And D. Antisocial personality disorder. So this question is referring to the information from part 1. I'll give you a second. You are correct. The answer is A. A hallmark of schizoid personality is withdrawal from social contact. Borderline personality disorder. So they are considered borderline between neurosis and psychosis, which is why this diagnosis is considered borderline personality disorder. So this person is also coined as thriving on conflict or chaos. So their extreme mood swings and fluctuations presents crisis and chaotic um, interpersonal relationship experiences. So the person may be unstable with the relationships. They may also have an unstable self-image of themselves. They may be marked by impulsive behaviors and have intense affect or behaviors. Common behaviors: chronic depression, bipolar, inability to be alone, clinging and distancing behaviors, splitting, manipulation, self-destructive behaviors, and impulsive behaviors. So, biological influences for predisposing factors include biochemical with a possible serotonergic defect, or we could have a genetic possibility with genes, family genes that connect with depression. Then we have our psychosocial influences, which include childhood trauma or abuse, developmental factors. So they may be fixed in a reapproachment phase of development, age 16 to 24 months. The child fails to achieve tasks of autonomy. So the child is not developing properly according to Erik Erikson's um, theory. A client diagnosed with borderline personality disorder is admitted to a psychiatric unit which behavior pattern would the nurse expect to observe? A. Social isolation. B. Suspiciousness of others. C. Bizarre speech patterns. D. Generates conflict among the staff. I'll give you a minute. And the answer is D. A client diagnosed with borderline personality disorder have little empathy toward others and are unable to accept positive and negative feelings and view others as all good or all bad. They tend to split staff, generate conflict. And we have ourselves a question. In assessing a client diagnosed with borderline personality disorder, which characteristic would the nurse expect to observe? A. Predictability. B. Controlled anger. C. Little tolerance for being alone. D. Stable and satisfactory relationships. I'll give you a minute. Correct. The answer is C. Clients diagnosed with borderline personality disorder have little tolerance for being alone. They prefer a frantic search for companionship, no matter how unsatisfactory, rather than experience feelings of loneliness, emptiness, and boredom. Please refer to Table 22-2 for your nursing diagnosis. I will not read through each of them word for word. So, risk for self-mutilation related to parental emotional deprivation. Then you have risk for suicide related to unresolved grief, risk for other directed violence, complicated grieving related to maternal deprivation, impaired social interaction related to extreme fears, disturbed personal identity related to underdeveloped ego, anxiety related to unconsciousness, chronic low self-esteem related to positive feedback. Outcomes for border personality disorder. So the client has not harmed themselves. So these are things we want to occur. They will seek out staff if they desire to do any self mutilating. They're able to identify the source of their anger, express their anger appropriately, relates to more than one staff member, completes activities of daily living independently, Does not manipulate one staff member against the other to fulfill desires. Planning and implementation phase for borderline personality disorder, risk for self-mutilation, and risk for self-directed or other directed violence. So you want to observe the client frequently. You want to try to redirect the violent behavior with physical outlets for the client's anxiety. Complicated grieving. Some of our interventions that we may plan to do is to convey accepting attitude, explore with the client the true source of their anger. Planning and implementation for borderline personality disorder, social interaction impairment. So help the client to understand that they will be available. Explore the feelings that are related to the fear of abandonment and engulfment. Evaluation of borderline personality disorder. So the evaluation of care for the client with borderline personality disorder is based on accomplishments of previously established outcome criteria. Antisocial personality disorders are often seen more frequently in prisons, jails, and rehabilitation services or centers, not so often in clinical settings. When these clients are seen, it is commonly a way of avoiding legal consequences. Sometimes they are admitted to the healthcare system by court for a psychological examination. Antisocial personality disorder, common behaviors, exploitation, manipulation of others for personal gain, belligerence or argumentative behavior, lack of remorse, inability to delay gratification, low frustration tolerance, inconsistent work or academic performance. Some common behaviors continued: failure to conform to society's norms, impulsive and reckless, inability to function as a responsible parent, inability to form lasting monogamous relationships. Predisposing factors for antisocial personality disorder. So it's possibly a genetic influence. They may have had disruptive behavior as a child and have conditions such as ADHD or conduct disorder, a history of severe physical abuse, absence or inconsistent parental discipline, extreme poverty, removal from the home. An individual with a history of antisocial personality disorder was arrested for driving under the influence of alcohol and causing a serious car accident. Which comment on this behavior would be expected? A. It is not my fault. B. I'm too ashamed to talk about it. C. I just don't remember doing it. D. I'm really sorry about all the people I've hurt. You're correct. The answer is A. Individuals diagnosed with antisocial personality disorder lack remorse about their actions and view themselves as victims. Nursing diagnosis for antisocial personality disorder. Refer to Table 22-4. So risk for other directed violence related to rage, reactions, negative role modeling. Defensive coping related to dysfunctional family system. Chronic low self-esteem related to repeated negative feedback. Nursing diagnosis, antisocial personality disorder continued. Impaired social interactions related to negative role modeling. Ineffective health maintenance evidenced by demonstration of inability to take responsibility. Antisocial personality disorder. The client will discuss feelings of anger with groups and staff. The client will not harm himself or others. The client will rechannel their hostility into socially appropriate behavior, and the client will follow rules and regulations of the therapy environment. Outcomes continued. So the client will verbalize his or her behaviors that are unacceptable. The client shows regard for the rights of others by delaying gratification for their own self when appropriate. The client does not manipulate others in an attempt to increase the feeling of self-worth. The client verbalizes understanding of knowledge and required to maintain their basic health needs. Planning intervention. So risks for violence directed at others. So convey accepting attitude, observe the client's behavior frequently, maintain and convey a calming attitude. Planning implementation continued. Defensive coping. Do not attempt to coax or convince the client to do the right thing. Provide positive feedback. Talk about past behaviors. Evaluation of care plan for the client with antisocial personality disorder is based on accomplishments of previously established outcome criteria. Treatment modalities for personality disorder includes interpersonal psychotherapy, psychoanalytic therapy, milieu group therapy, cognitive behavioral therapy, dialectical behavioral therapy, and psychopharmacological treatment methods.